Welcome back to the Deep Dive.
Yeah.
Today, we're really immersing ourselves in what has to be one of the most incredible medical advances, I think, of the last couple of decades.
Yeah, absolutely. We're tackling the fight against immunological incompatibility in organ transplantation, specifically kidney transplantation.
Right. Kidney transplantation, it should be this moment of pure victory,
Mhm.
But for thousands, literally thousands of patients, the ones we call highly sensitized, it actually kicks off this frantic battle against their own bodies.
It's a battle against biology itself. It stems from that fundamental barrier when a donor organ, even from a willing donor, is just biologically set up for immediate rejection by the recipient's immune system.
And we're talking about things like HLA mismatches,
Ah.
human leukocyte antigen.
Exactly, the HLA system. Or sometimes it's even the basic ABO blood group incompatibility. These immunological walls, historically, they've kept patients just chained to dialysis machines, sometimes for years and years.
Waiting for that perfect match that, for many, just never comes.
Precisely.
So our deep dive today is all about the strategies, these really groundbreaking approaches that are starting to dismantle those walls. We're going to zero in on desensitization protocols.
And the tools they use, the specialized arsenal of therapeutic apheresis techniques.
Right. We want to show you, really get into how medical teams can literally filter and, well, reprogram a patient's blood so it accepts an organ it previously would have destroyed.
Yeah, our mission here is to give you that shortcut, that inside look at how doctors are turning these impossible transplants into actual life-saving successes. We'll break down the protocols.
Look at the different blood cleaning technologies, what they do.
Compare them, yeah. And then look ahead, right? To the ultimate frontier, which has to be xenotransplantation.
Using pig organs. It sounds like science fiction, but it's happening.
It is. And it promises, potentially, to solve the organ scarcity problem altogether.
So we're really uncovering the science that makes the previously impossible transplant possible, giving you, the listener, the knowledge to appreciate just how complex, but also how successful modern transplant medicine has become. Okay, let's kick things off right there. The immunological barrier. We hear this term all the time, highly sensitized patient. What does that actually mean at like a molecular level? What makes someone sensitized, and why is that incompatibility often a death sentence for the graft?
It really boils down to antibodies, specifically antibodies that are already floating around in the recipient's blood before the transplant even happens.
Oh, where do they come from?
Sensitization usually occurs because the patient's immune system has encountered foreign HLA antigens before. This could be from a previous, maybe failed transplant, or from multiple blood transfusions over the years. And very commonly for women, it happens through pregnancy, encountering the father's HLA antigens via the fetus.
Ah, okay, so these past exposures create a kind of immune memory.
Exactly. They generate what we call donor-specific antibodies, or DSAs. So when a potential donor organ comes along, we do a test called a cross-match. If those pre-existing DSAs in the recipient recognize the donor's HLA type,
That's a positive cross-match.
that's a positive cross-match. And it signals that catastrophic hyperacute rejection is almost guaranteed if the transplant proceeds. The immune system attacks immediately.
So if we know those sort of killer DSAs are present, the whole point of desensitization isn't necessarily to change the patient's immune system forever, right? It's more about temporarily getting rid of or suppressing those specific antibodies.
That's the core idea, yeah. We need to lower the levels of those harmful DSAs just enough, and for long enough, to allow the surgery to happen safely and for the initial immunosuppression to take hold.
Okay, so let's walk through the standard approach then for HLA-incompatible transplantation.
Yeah.
What does that protocol usually look like?
It's typically a multi-pronged attack, hitting the problem from different angles. It usually involves three main components, often given over several weeks leading up to the surgery. The absolute centerpiece is plasmapheresis, or PEX, sometimes called therapeutic plasma exchange, TPE.
PEX, that sounds like the direct approach, physically removing the plasma.
It is. It's the brute force method, as you said. PEX physically washes out the patient's plasma, which is where the antibodies circulate. So you get this rapid, immediate drop in antibody levels.
But I imagine the body doesn't just sit back and accept that. It tries to make more, right?
Exactly. That's the big challenge with PEX alone. The moment you remove antibodies, the body's mechanisms kick in to replenish the supply. There's a rebound, and that's where the other components of the protocol come in. They're designed to manage that rebound.
Okay, so you need something to stop new antibodies from being made, and maybe something else to kind of calm the whole system down.
Precisely. The second key component is usually rituximab. This is a type of drug called an anti-CD20 monoclonal antibody.
Okay, what does CD20 have to do with it?
CD20 is a protein found on the surface of B cells. B cells are the immune cells that mature into plasma cells.
Which are the antibody factory.
The antibody factories, exactly. So by giving rituximab before the transplant, you target and deplete these B cells. You essentially shut down the production line for new antibodies, preventing that rebound, or at least significantly blunting it.
Makes sense. Remove the existing ones with PEX, stop new ones with rituximab. What's the third piece? You mentioned low-dose IVIG, intravenous immunoglobulin.
Yes. IVIG. Now, this one seems a bit counterintuitive at first.
Yeah, because immunoglobulin is antibody, right? Why add more antibodies from other people into this already tricky situation?
It's a great question. IVIG plays a really interesting dual role here. First, giving it after PEX does help occupy some of the space, preventing that immediate sharp rebound of the harmful DSAs. But its more profound effect is as an immune modulator. IVIG is a pooled product containing a huge spectrum of normal human antibodies from thousands of donors. These good antibodies can do several things. They can saturate certain receptors on immune cells, like SEC receptors. They can block the complement system from activating. And they generally interfere with the inflammatory pathways that drive rejection and further antibody production. It sort of gently pushes the whole immune system toward a state of tolerance, calms things down.
Okay, so it's PEX for removal, rituximab to stop production, and IVIG to kind of modulate and prevent rebound. That sounds like a really intensive combination of treatments. It must carry risks, infection, side effects from the drugs.
Oh, absolutely. There are definite risks involved. Increased susceptibility to infection is a major one, plus potential reactions to the drugs or the apheresis procedure itself.
So why do it? What's the justification? I think this is where the data you mentioned earlier from the source material becomes really powerful. Can you tell us about that landmark Johns Hopkins trial?
This data really is the foundation for why we do this. The Johns Hopkins group followed a cohort of patients who received HLA-incompatible kidney transplants after undergoing this aggressive PEX-IVIG rituximab desensitization. The results were, frankly, astounding.
What do they find?
They achieved an 8-year patient survival rate of approximately 80%. 80%.
80% survival at 8 years for patients who got an incompatible kidney. That's remarkable.
But you have to compare it to the alternative, right?
Exactly. What happens to similar highly sensitized patients if they don't get the incompatible transplant? They stay on the waiting list, usually on long-term dialysis.
And the survival for them.
For those patients stuck on dialysis, the 8-year survival rate plummets. We're talking only 30 to 50%.
Wow. So less than half the survival rate compared to getting the desensitizing incompatible transplant.
The difference is just stark. And it's crucial to remember, dialysis isn't a benign state. It's not just waiting. Long-term dialysis carries a significantly higher risk of death, particularly from cardiovascular disease, infections, just overall frailty. So the risk of dying while waiting for that perfect match, which might never come,
far, far outweighs the risks associated with the desensitization process itself. This evidence really shifted the thinking. It made the calculation clear. For these highly sensitized patients, desensitization isn't just an option, it's often a life-saving necessity.
That completely reframes it. You're not just trading one set of risks for another, you're taking patients out of a very high mortality situation, chronic dialysis, and giving them a much better chance at long-term survival.
Absolutely. It's about actively extending life, not just improving quality of life, although it does that too.
And science doesn't stand still. Well, this PEX-IVIG rituximab protocol is sort of the standard.
Yeah.
Are there newer things come along? You mentioned something called imlifidase.
Yes. Imlifidase is a fascinating newer agent, gaining traction particularly in Europe. It's an enzyme, specifically an IgG endopeptidase.
Okay, an enzyme that breaks down IgG antibodies. How's that different from PEX just washing them out?
It's much more targeted, like a molecular scalpel. IgG antibodies have this characteristic Y shape. Imlifidase very specifically cuts the antibody's heavy chain just below the hinge region.
Ah, so it breaks the Y into pieces.
Exactly. It separates the antibody into fragments that are essentially harmless.
All right.
So the really striking thing is how fast it works. It can cleave almost all circulating IgG within hours of administration.
Hours. So you could potentially transplant someone almost immediately after giving the drug.
That's the potential, yes. It offers incredibly rapid desensitization. You could theoretically give imlifidase and proceed with transplantation just hours later. And this is a critical but.
There's always a but.
There's always a but.
Yeah.
Because imlifidase only destroys the circulating antibodies. It doesn't touch the B cells or the plasma cells, the factories making them.
So the effect is temporary.
Entirely transient, yes. You get a very rapid drop, which is great for getting the transplant done, but those factories are still churning out new antibodies. This means you absolutely need robust, immediate follow-up immunosuppression, probably including things like rituximab or other agents, to prevent a very swift and potentially dangerous rebound of DSAs.
Okay, so imlifidase is like a quick, powerful opener, but you still need the full playbook afterwards to keep things under control. What's sort of bottom line clinical guidance for these high-risk HLA patients then?
The guidance from major transplant societies is pretty unified on this. First and foremost, always try kidney paired donation, or KPE.
Where you swap donors between incompatible pairs to find compatible matches.
Exactly. That should always be the first port of call if there's a living donor involved. But if KPE doesn't yield a suitable match within a reasonable time frame, and for patients with very high cPRA, calculated PRA, it often doesn't, then proceeding with HLA-incompatible desensitization is considered a reasonable and often necessary approach.
You don't just leave them languishing on dialysis and deficit.
You can't. The mortality risk is just too high. Desensitization is justified for carefully selected patients in that situation.
Okay, let's switch gears a bit. We've talked HLA. What about the other big barrier? ABO blood type incompatibilities. These used to be an absolute no-go, right? You just could not transplant across blood types.
Absolutely. For decades, ABO incompatibility was considered an absolute contraindication for kidney transplantation, but now it's become almost routine at experienced centers. It's a huge success story.
How do we crack that one? Is the science similar to HLA?
The basic principle is identical. Find the harmful antibodies and get rid of them. In ABO incompatibility, the main targets are the antibodies against the A or B blood group antigens. They're called isohemagglutinin.
Isohemagglutinin, okay.
These are mostly, though not exclusively, IgM-class antibodies. They're quite large molecules. If you put, say, an A kidney into a B recipient, these pre-existing anti-A isohemagglutinins cause immediate massive destruction of the graft via complement activation, a very rapid rejection.
So the ABO-incompatible, or ABO protocol, must focus on getting those isohemagglutinin levels down.
Exactly. The goal is very precise. Reduce the titer, which is the concentration of the anti-A or anti-B antibodies, to an acceptably low level before the surgery. Typically, centers aim for a titer of 1.16 or even lower, like 1.8.
And how do they achieve that? Is it PECs again?
It can be PECs, yes. But often, for ABO, centers prefer using antigen-specific immunoadsorption.
Like we discussed with HLA, but even more specific.
Even more specific. Because we know the exact target, the A antigen or the B antigen, we can create columns containing synthetic versions of these A or B sugar molecules. When the patient's plasma flows over the column, only the anti-A or anti-B antibodies bind and get removed. Everything else flows through.
That sounds much cleaner than non-specific PECs.
It generally is. It avoids removing other important plasma components. So either PECs or this specific immunoadsorption is used to get the titer down pre-op.
Do they still need rituximab for ABO, given that the main antibodies are IgM, not IgG, made by long-lived plasma cells?
That's a good point. While the primary targets are IgM, most ABO protocols do still include a single dose of rituximab pre-transplant.
Why is that?
There are a couple of reasons. First, while mostly IgM, there can be an IgG component to isohemagglutinins too. Second, you want to suppress the B cells to prevent them from potentially making new IgM or undergoing class switching later on, where they might start producing more harmful IgG antibodies against the ABO antigens post-transplant. So rituximab provides an extra layer of security.
Okay, and the results? How successful is ABO transplantation now?
The success rates are truly remarkable. Multiple large series report one-year graft survival rates around 96% and patient survival around 98%. That's virtually identical to outcomes seen in standard compatible transplants. It's an incredible achievement.
96% graft survival at 1 year. That's fantastic. What happens after the surgery? Do patients constantly have to fight off low levels of these anti-ABO antibodies, or does something else happen?
This leads to a phenomenon that I personally find absolutely fascinating. It's called accommodation.
Accommodation, what's that?
Accommodation is this biological process where, over time, the transplanted organ itself somehow becomes resistant to injury from any remaining low levels of the recipient's anti-A or anti-B antibodies.
Wait, the organ adapts. It learns to live with the antibodies. How on earth does it do that? That sounds almost sentient.
It's not quite sentient, but it is an active adaptation. The current understanding involves a couple of key mechanisms happening within the endothelium, the lining of the blood vessels in the graft.
Okay.
First, the endothelial cells might actually reduce the expression of the target ABO antigens, A or B, on their surface. They essentially try to hide the target from the antibodies.
Lowering their profile.
Exactly. Second, and probably more importantly, the endothelial cells seem to activate protective cellular pathways. They start expressing higher levels of anti-inflammatory molecules and, crucially, complement regulatory proteins on their surface.
Like the ones engineered into the pigs for xenotransplantation.
Precisely like those. Things like CD55, CD59. These proteins act like shields, actively inhibiting the complement cascade if an antibody does bind. So even if some residual anti-ABO antibodies are present and bind, they can't trigger the damaging inflammatory reaction. The graft becomes tolerant or accommodated to their presence.
That is amazing. So the kidney essentially builds its own defense system against the specific threat it faces. That explains why the long-term outcomes can be so good, approaching compatible transplants.
It does. The initial desensitization gets you through the critical early phase, breaching that acute barrier. Then, accommodation helps minimize the risk of chronic injury from those residual antibodies over the long haul.
Does this phenomenon of accommodation also have implications for how much immunosuppression these patients need long-term?
That's an area of active research and debate. Theoretically, if the graft becomes truly accommodated, it might suggest that we could potentially reduce immunosuppression more significantly or faster in stable ABO recipients compared to, say, highly sensitized HLA-incompatible recipients who might always have a risk of DSA rebound. But that needs careful study.
And one last point on ABO, what about kids? Is it different for them? The outline mentions infants often require minimal apheresis.
Yes, that's a key difference. Very young children, especially infants under 1 or 2 years old, naturally have very low levels of these isohemagglutinin.
Why is that?
Their immune systems just haven't matured enough or been exposed to the common environmental antigens like bacteria in the gut that cross-react with A and B antigens and stimulate the production of these antibodies in older children and adults.
So they don't have high titers to begin with.
Exactly, which means they often require far fewer apheresis sessions before an ABO transplant, sometimes even none at all, particularly if the starting titer is already low. This makes ABO transplantation a very feasible and attractive option in pediatrics, minimizing the risks and logistical challenges associated with intensive apheresis in small children, and the outcomes are excellent.
Okay, so we've established that removing antibodies using therapeutic apheresis is absolutely central to both HLA and ABO desensitization and also for treating rejection. Let's dive a bit deeper into the tools themselves. For someone listening who isn't familiar, can you just define apheresis again? What's the basic idea?
Sure. Therapeutic apheresis is essentially a process of blood cleaning that happens outside the body. It's an extracorporeal therapy. Blood is drawn from the patient, passed through a machine that separates it into different components.
Like cells and plasma?
Exactly. Then, specific disease-causing components in our context, mostly harmful antibodies, but also sometimes immune complexes or inflammatory mediators, are removed from the separated plasma. Finally, the clean blood components are recombined and returned to the patient.
And the main workhorse, the sort of first-line tool you mentioned, is plasmapheresis, or therapeutic plasma exchange, TPE. Let's really get into the mechanics of that. How does PEX work?
PEX is fundamentally nonspecific in what it removes from the plasma. The patient's blood goes into the apheresis machine where it's separated, usually either by a centrifuge spinning rapidly or by passing through a membrane filter. This separates the cellular parts, red cells, white cells, platelets, from the liquid plasma.
And the plasma contains the antibodies we want to remove.
Correct. In standard PEX-TPE, that antibody-rich plasma is simply discarded. It's removed entirely.
And you can't just return the cells dry, right? You need to replace the volume.
Exactly. You have to replace the volume of plasma that was removed. This is usually done with a large volume of a replacement fluid, most commonly albumin solution, which maintains osmotic pressure. Less frequently these days, donor plasma, like fresh frozen plasma, FFP, might be used, but that carries its own risks. The cells are mixed with this replacement fluid and then returned to the patient.
So it's a total plasma washout. You said it's the go-to for acute situations.
Yes, it's the gold standard for rapid, acute depletion of circulating antibodies. That makes it first-line therapy for pre-transplant desensitization protocols and also critically important for treating episodes of acute antibody-mediated rejection, ABMR, that can happen after the transplant.
But you highlighted the challenge before the rebound. Antibodies come back quickly. How fast is that rebound, and what does it mean for treatment schedules?
The rebound is surprisingly fast. While the natural half-life of IgG antibodies in the blood is around 3 weeks, PEX triggers a rapid compensatory response. Antibodies stored in the tissues, in the extravascular space, quickly move back into the bloodstream to replace what was removed.
So the levels shoot back up?
They can, yes. Studies show that IgG levels can return to about 60% of their pre-PEX baseline within just 48 hours after a single large volume session, 60% in 2 days.
Wow. Okay, so one session is definitely not enough.
Absolutely not. This rapid reequilibration is precisely why PEX is never a one-off treatment for desensitization. You need a series of sessions, typically 5 to 7 exchanges, often performed daily or every other day, to keep knocking those antibody levels down repeatedly. The goal is to maintain suppression long enough for the other drugs, like rituximab, to take effect and shut down the antibody production side of things.
Beyond just physically removing antibodies, you mentioned PEX might have other, more subtle immune modulating effects. What are those?
It does seem to. By removing not just antibodies but also other inflammatory factors, cytokines, and complement components from the plasma, PEX can help to generally cool down the immune system. There's some evidence suggesting it might enhance the function of certain regulatory T cells, the suppressor cells.
The brakes on the immune system.
The brakes, exactly, and perhaps shift the balance of other T cell populations. It's thought that this general calming effect might make the remaining immune cells more susceptible or responsive to the standard anti-rejection drugs being given concurrently. So it's not just about antibody removal.
That leads to a really critical practical point we need to stress: drug timing. If PEX is nonspecific and just removes plasma, it must remove drugs dissolved in the plasma too, right? How do transplant centers handle giving crucial immunosuppressants, like rituximab or maybe ATG, antithymocyte globulin, around PEX sessions?
This is a huge logistical and pharmacological consideration. You're absolutely right. PEX can remove a significant portion, potentially up to 50% or even more, of large molecule therapeutic drugs like monoclonal antibodies or immunoglobulin preparations if they're circulating in the plasma when the procedure is done.
So giving the drug right before PEX would be wasteful.
Worse than wasteful, it could be dangerous. If you give a critical dose of rituximab or ATG and then immediately run the patient through PEX, you risk washing away a huge chunk of that dose. This could lead to inadequate immunosuppression precisely when the patient needs it most, potentially allowing antibody rebound or rejection to occur.
So what's the rule then?
The absolute standard of care, the hard and fast rule, is that these large molecule immunosuppressive drugs must always be administered after the PEX session is finished for the day. You do the apheresis first, then give the drug dose. That ensures maximum drug exposure and efficacy. Timing is everything.
Okay, standard PEX is the workhorse. But you mentioned more specialized, more precise tools. Let's talk about double filtration plasmapheresis, DFPP. How does adding a second filter improve things?
DFPP is essentially a clever mechanical upgrade on standard PEX. In PEX, remember, we discard all the plasma. In DFPP, the process starts the same. Blood is separated into cells and plasma using a first filter, the plasma separator. But then, crucially, the separated plasma is not discarded.
Okay, what happens to it?
It gets passed through a second filter, called a plasma fractionator. This second filter has pores of a very specific size. These pores are large enough to let smaller essential plasma components like albumin, electrolytes, most clotting factors pass through easily. But they are small enough to retain the much larger molecules we want to remove, like IgG antibodies, especially IgM, and large immune complexes.
So it selectively filters the plasma itself, and the stuff that passes through the second filter gets returned.
Exactly. The cleaned plasma fraction containing the good stuff is recombined with the patient's cells and returned. Only the fraction containing the large pathogenic molecules is discarded.
So it's more selective than PEX. Where does DFPP fit in clinically? Is it better for certain situations?
It offers more efficient removal of those high molecular weight substances, particularly large antibodies like IgM or IgG immune complexes. We often quantify antibody levels using MFI mean fluorescence intensity. Standard PEX is generally effective for DSAs up to an MFI of around, say, 9,000. The FPP might push that envelope a bit higher, maybe handling MFIs up to around 12,000 effectively.
And presumably, because you're returning some of the patient's own plasma components, you need less replacement fluid.
That's another potential benefit, yes. It can reduce the need for large volumes of albumin or donor plasma, which can be advantageous. So it's a step up in selectivity and efficiency from standard PEX.
Then we get to what sounds like the most sophisticated option, immunoadsorption, IA. You describe this as less like a filter and more like a chemical trap. How does IA work?
IA is indeed highly specific, operating on the principle of affinity binding rather than size filtration. Again, the patient's plasma is separated from the cells, but instead of being filtered or discarded, this plasma is then passed over a column, an immunoadsorption column.
And this column is coated with something specific.
Exactly. The column contains ligands molecules that have a high chemical affinity for, and therefore bind tightly to, the specific substance we want to remove. For general IgG removal and HLA desensitization, a common ligand used is protein A, a bacterial protein that binds very strongly to the FSC region, the tail part of most IgG antibodies.
So the IgA would stick to the column.
They stick tightly. For ABO desensitization, as we discussed, you'd use columns coated with synthetic A or B antigens to specifically bind only the anti-A or anti-B antibodies. The plasma flows through the column, the target antibodies get trapped, and the clean plasma, now depleted of those specific antibodies but with everything else intact, flows out the other side and is returned to the patient.
That sounds incredibly precise. What's the big clinical advantage that justifies what I assume is a higher cost for IA compared to PEX or DFPP?
The major advantage is that extreme specificity, which translates directly into improved safety and potentially better logistics. Because IA only removes the target immunoglobulins, mostly IgG or the specific isohemagglutinin, it leaves virtually all other essential plasma proteins completely untouched.
Like albumin, clotting factors.
Albumin, clotting factors, fibrinogen, complement components, they all pass through unharmed. This dramatically reduces the risk of coagulation problems or other side effects associated with removing these factors non-specifically, as happens in PEX. And critically, it often completely eliminates the need for any replacement fluids like albumin or donor plasma.
Which saves cost on replacement fluids and avoids the risks of transfusion.
Precisely. It simplifies the procedure from that perspective. Also, many IA columns can be regenerated, the bound antibodies can be washed off, and the column reused multiple times for the same patient, which helps manage costs over a course of treatment. And because it's so efficient at binding, IA can often handle very high antibody levels, potentially MFIs of 15,000 or even higher, where PEX or DFPP might struggle.
So the choice between PEX, DFPP, and IA really comes down to a balance of factors, like how high the antibody level is, the specific target, cost, and what technology the transplant center has available.
That's exactly right. PEX is the widely available, cost-effective workhorse for many situations. DFTP offers a bit more selectivity, and IA is generally reserved for the highest-risk patients with very strong antibodies, or where avoiding replacement fluids is a major priority, or for specific targets like ABO antibodies where antigen-specific columns are available. It's about tailoring the tool to the specific immunological challenge.
Okay, one last apheresis modality to touch on again. Lipoprotein apheresis, or lipopheresis liposorption. We mentioned its main use isn't antibody removal, but treating recurrent FSGS. Just to recap, how does removing lipoproteins help in that specific kidney disease?
Right, lipopheresis uses columns that selectively absorb or bind lipoproteins containing epiluoprotein B, basically LDL, bad cholesterol, and VLDL. It doesn't significantly pull out IgG or clotting factors. Its use in FSGS, focal segmental glomerulosclerosis, stems from the theory that when FSGS recurs in a transplant, it's driven by some kind of circulating permeability factor.
A mysterious substance that damages the kidney's filters.
Exactly. It makes the glomeruli leaky, causing massive protein loss in the urine. The hypothesis, still not fully proven, but strongly suggested by clinical results, is that this permeability factor might be carried on or associated with these large lipoprotein molecules.
So removing the lipoproteins might remove the factor along with them.
That's the leading idea. By performing lipoprotein apheresis, you might be clearing this putative factor from the circulation, thereby stopping the damage to the transplanted kidney's filters and reducing the proteinuria. It's a very niche but sometimes highly effective application of apheresis in the transplant setting, quite distinct from antibody removal for desensitization or rejection.
Let's focus now specifically on that post-transplant complication, FSGS recurrence. You hear about this and it sounds absolutely terrifying for patients and doctors. The original disease coming back and potentially destroying the brand new kidney very quickly.
It is devastating when it happens. Primary FSGS, the original kidney disease, has a disturbingly high rate of recurrence in the transplanted kidney. Estimates vary, but it can be anywhere from 30% up to maybe even 60% in patients receiving their first transplant for FSGS.
And it happens fast.
Often, yes. Clinically, it typically presents with a sudden, dramatic onset of nephrotic range proteinuria, massive amounts of protein leaking into the urine. This can happen within hours or days of the transplant surgery, and if it's not recognized and treated promptly, the damage to the new kidney's glomeruli can progress very rapidly, potentially leading to irreversible graft failure.
That speed implies that immediate action is crucial. If recurrence is suspected, what's the absolute first thing that needs to happen?
The cornerstone of therapy, the non-negotiable first step, is to initiate plasmapheresis immediately.
Don't wait for confirmation, just start.
Pretty much. The urgency cannot be overstated. We saw data from a meta-analysis that really hammered this home. Overall, about 71% of patients treated with PEX for recurrent FSGS achieved at least a partial remission, meaning their proteinuria decreased significantly. But the crucial factor influencing success was timing.
How critical was the timing?
Starting PEX within 2 weeks of the recurrence being diagnosed was strongly associated with a much higher chance of achieving remission and salvaging the graft. Delaying treatment significantly worsens the prognosis. So the clinical mantra is really, if you suspect FSGS recurrence based on rising proteinuria, start PEX now, ask questions later. The clock is ticking loudly.
Okay, so PEX is started immediately. What else is typically done? Is it just PEX alone, or is it combined with other intensified therapies?
It's almost always used in combination with intensified systemic immunosuppression. PEX removes the putative permeability factor, but you also need to suppress the underlying immune process that might be contributing to it. So patients will typically receive high-dose corticosteroids.
Steroids, yeah.
Calcineurin inhibitors like tacrolimus or cyclosporine are often maximized, and frequently, rituximab is added to the mix.
Why rituximab again? Is there thought to be an antibody involved in FSGS recurrence too?
The exact nature of the permeability factor is still debated, but there's a significant body of evidence suggesting it might be related to abnormal B-cell function or possibly an antibody or immune complex. So targeting B cells with rituximab makes sense as part of the multi-pronged attack.
And what if that combination PEX plus intensified immunosuppression still doesn't work? Are there other options for refractory cases?
For cases that don't respond, especially in pediatric patients where recurrence can be particularly aggressive, there has been notable success reported with adding agents like cyclophosphamide.
Cyclophosphamide, that's a potent chemotherapy drug, right?
It is. It's a strong immunosuppressant. One significant case series, particularly in children with recurrent FSGS refractory to other treatments, showed that combining PEX with cyclophosphamide led to complete remission in a very high percentage of patients, something like 15 out of 17 kids in that report. So it's a powerful rescue therapy option.
And this is also where lipoprotein apheresis, the cholesterol-removing kind, finds its niche, right? As an add-on if standard PEX isn't cutting it.
Precisely. If a patient has FSGS recurrence that's resistant to standard PEX and drug therapy, or if they have multiple recurrences, lipoprotein apheresis can be considered as an adjunct treatment. As we discussed, the theory is removing large circulating lipoproteins might help clear the permeability factor. Small studies have shown it can be effective in reducing proteinuria in these difficult cases.
And the evidence for PEX in recurrent FSGS is strong enough that it's considered standard practice.
Absolutely. The American Society for Apheresis, ASFA guidelines, classify the use of PEX for recurrent FSGS as a Category I indication. That means it's considered a first-line, standard, and accepted therapy based on strong evidence.
Okay, let's shift from a specific disease recurrence to a broader measure of risk for transplant candidates. Panel reactive antibodies, PRA, or the more modern version, calculated PRA, cPRA. What exactly is this telling us?
PRA, and especially the more accurate cPRA, is essentially a statistical estimate of how broadly sensitized a patient is against the general donor pool. It represents the percentage of potential donors in the population whose HLA antigens the patient already has antibodies against.
So if someone has a cPRA of, say, 98%.
That means that statistically, 98 out of every 100 potential deceased or living donors would carry HLA antigens that this patient's pre-existing antibodies would recognize and attack. It means finding a compatible donor organ for them will be incredibly difficult.
It's a direct measure of how hard it will be to find a match, and it must correlate with waiting time on the list.
Directly and often terrifyingly so. Patients with very high cPRA, 98%, 99%, even 100% face years, often many years, on the transplant waitlist with a very low probability of receiving a compatible deceased donor kidney offer through standard allocation.
For someone at 99% or 100% cPRA, finding a compatible kidney through just random chance seems almost impossible. How do the organ allocation systems try to address this inequity?
The allocation systems, like the one used in the U.S. managed by UNOS, explicitly recognize the disadvantage faced by these highly sensitized patients. They know that high cPRA equates to a higher risk of dying while waiting, so the system gives these patients extra points.
To bump them up the list.
Essentially, yes. Candidates with a cPRA of 98% or higher receive significant extra allocation points, and those at 99% or 100% often get national priority, meaning they are considered for compatible organs appearing anywhere in the country, not just locally or regionally. It's an attempt to level the playing field somewhere.
But even with priority points, the odds are still long. You mentioned kidney paired exchange. KPE should always be tried first for these patients if they have a willing but incompatible living donor.
Absolutely. KPE, the donor swapping programs, offer the best chance for many highly sensitized patients to find a compatible living donor transplant. It should always be explored aggressively before considering other options.
But KPE isn't guaranteed to find a match either, especially for the very broadly sensitized. So for that patient with 99.9% cPRA, where KPE hasn't worked, desensitization becomes, well, less of an option and more of a critical decision, right? Balancing risks again.
It's exactly that risk calculation again, but the scales are heavily weighted. When a patient is facing near certain incompatibility with almost any donor, the logistical challenge of finding a compatible match, even with allocation points and KPE, can seem insurmountable. In that context, the known immunological risks of undergoing aggressive desensitization, the risk of infection, the risk of potential early rejection episodes are often deemed acceptable because they are weighed against the near certainty of continued high mortality risk if the patient simply remains on long-term dialysis.
It comes back to that Hopkins data, 80% survival with desensitization versus 30–50% on dialysis.
Precisely. Desensitization protocols take a situation that looks like a dead end and transform it into a realistic path towards significantly improved long-term survival. It justifies the upfront risks.
And logically, once a highly sensitized patient does get transplanted, either through desensitization or maybe a rare compatible match, their post-transplant management must be different, more intense.
Definitely. Vigilance is the key word. Post-transplant care for these high PRA patients typically involves significantly augmented immunosuppression compared to a standard recipient. They might be on more potent drug combinations or higher doses initially.
And more monitoring.
Much closer monitoring. They are watched very carefully for any signs of DSA rebound, the reappearance or increase in those donor-specific antibodies after the transplant, which can be an early warning sign of impending rejection. Some centers even employ prophylactic strategies.
Like giving treatments even if there's no rejection yet.
Exactly. Prophylactic PEC sessions or IVIG infusions might be scheduled in the immediate postoperative period purely as a preventative measure to keep any potential antibody rebound suppressed. We also sometimes see the prophylactic use of complement inhibitors, like eculizumab, administered around the time of the transplant surgery itself, aiming to preemptively block the complement cascade just in case hyperacute or early acute AMR tries to occur. It's about staying one step ahead of the sensitized immune system.
All right, let's shift our gaze to the future. We've been talking about managing scarcity and incompatibility within human-to-human donation. But if the fundamental problem is just not enough human organs, the ultimate dream solution has always been xenotransplantation using organs from another species. And now, using genetically engineered pig organs, well, it's not a dream anymore. It's actually happening.
It really is the next frontier, and the progress in just the last 5 to 10 years has been absolutely breathtaking. Pigs are considered the most promising source for xenografts because their organs, kidneys, hearts, livers are remarkably similar in size and physiological function to human organs.
But historically, putting a pig organ into a human led to immediate, violent rejection, right?
Instantaneous, hyperacute rejection. Within minutes, the human immune system recognized it as profoundly foreign. The key breakthroughs have been in using genetic engineering to overcome the major immunological barriers, primarily that hyperacute rejection, but also the subsequent challenges of acute and chronic rejection.
Okay, let's unpack the engineering. How do scientists modify the pigs to stop that immediate hyperacute rejection? What's the main target they eliminate?
The primary trigger for hyper-Q rejection is the presence of specific sugar molecules, carbohydrate antigens, on the surface of pig cells that humans have natural preformed antibodies against. The most important one is called alpha-gal, galactose alpha 1 or 3 galactose.
Alpha-gal. Got it.
So the first crucial step in creating suitable donor pigs was to use gene editing techniques like CRISPR to knock out the genes responsible for making these key carbohydrate antigens. Most advanced donor pigs used today are often referred to as triple knockout, TKO, pigs.
TKO, meaning they've knocked out 3 genes.
Yes. Typically, the gene for alpha-gal plus 2 other important carbohydrate antigens called NU5GC and SAUDA. By eliminating these 3 major targets, you effectively remove the primary triggers that cause that immediate catastrophic rejection by preformed human antibodies.
So step 1 is removing the red flags that the human immune system instantly recognizes. What about making the pig organ actively defend itself against the human immune response that still occurs?
That's the second major strategy, adding human genes into the pig genome. This is often called creating transgenic pigs. They are engineered to express specific human proteins that help regulate the human immune system, particularly the complement system.
Complement that destructive cascade again.
Exactly. So these pigs are engineered to express human complement regulatory proteins right on the surface of their cells. Common ones added are human CD55, also known as decay accelerating factor, DAF, and human CD46, membrane cofactor protein, MCP.
And these human proteins on the pig cells act like brakes on the human complement system.
Precisely. When the pig organ is transplanted, these human proteins actively work to shut down the human complement cascade if it gets activated, preventing it from damaging the pig tissue. It's like giving the pig organ its own built-in human defense shield against that part of the immune attack.
Incredible. Removing the targets, adding the shields, and the clinical progress resulting from this engineering has been dramatic recently.
Absolutely stunning. In preclinical studies using these multi-gene edited pigs, we saw pig kidneys surviving for over 2 years in non-human primate recipients, which was a huge milestone.
Baboons, usually.
Often baboons, yes. And then came the landmark human studies, starting around 2021. Initially, in brain-dead human recipients, showing the pig kidneys could successfully attach, make urine, and clear waste products like creatinine.
Proof of concept in humans.
Exactly. And then, more recently, the first transplants into living human patients. The case you mentioned earlier, where a recipient lived for 130 days dialysis-free with the gene-edited pig kidney, was a monumental step forward. It demonstrated sustained life support is possible.
And this progress is what led the FDA to greenlight initial clinical trials. Yes. Based on this accumulating preclinical and initial human data, the FDA gave approval for the first phase 1 clinical trials of pig kidney xenotransplantation in living recipients, expected to begin in earnest around 2025. It's a pivotal moment.
But even with all this sophisticated genetic modification, TKO plus human transgenes, immunological rejection still happens later on, right? Days or weeks after the transplant. What's the main challenge that remains?
The remaining challenges look remarkably similar to what we see in human-to-human transplantation, particularly in sensitized patients. We still see episodes of antibody-mediated rejection, AMR, occurring. The pig organs, even heavily modified, still express other pig antigens, non-gal antigens, protein differences, that the human immune system can recognize and react against over time.
Okay, so delayed rejection is still a hurdle. But here's something fascinating from the source material, this idea of immunological overlap. You mentioned that antibodies against human HLA can actually cross-react with pig tissues. This was a really crucial and perhaps initially surprising discovery. It turns out that some of the anti-HLA antibodies that highly sensitized human patients develop from prior transplants, transfusions, pregnancies, can indeed recognize and bind to the pig equivalent of HLA, which is called SLA, swine leukocyte antigen.
SLA. So the immune memory built up against other humans can actually target the pig organ too.
In some cases, yes. There's enough structural similarity between certain HLA and SLA molecules that these antibodies cross-react. This has a profound implication.
Which is?
It means that the very same patients who are highly sensitized and difficult to transplant with a human organ, the high-prac-peri patients, are also likely to be immunologically high risk for receiving a xenograft. They aren't starting with a clean slate immunologically when it comes to the pig organ. Their anti-HLA memory might directly contribute to rejecting the xenograft.
That is a huge insight. It connects the two fields directly. It means the problem of sensitization isn't solved just by switching species.
Exactly. But the flip side is also incredibly important.
Which is that the tools we develop to deal with HLO sensitization might work for xenografts too.
Precisely. All the experience, the protocols, the drugs, the apheresis techniques we've honed over decades for managing HLA incompatibility and desensitizing human recipients, they are directly relevant and potentially applicable to managing the immune response in xenotransplantation. We're not necessarily inventing entirely new approaches, we're adapting and refining the ones we already have.
Which brings us right back to therapeutic apheresis. It must have an immediate, obvious role in the xenotransplant setting, especially for potentially sensitized recipients.
It absolutely does, and it's already being used. There was a very informative case study published involving one of the brain-dead human recipients who received a multi-gene edited pig kidney. This particular recipient was known to be sensitized, had pre-existing anti-HLA antibodies. Post-transplant, the team detected early signs of antibody-mediated rejection developing in the pig kidney. So what did they do? They immediately implemented the standard protocol used for treating AMR in human-to-human transplants. They initiated post-transplant plasmapheresis, PEX, and gave intravenous immunoglobulin, IVIG.
The same PEX-IVIG combination we use for human rejection. And did it work?
Remarkably well, yes. The PEX and IVIG successfully mitigated the antibody-mediated injury, reversed the signs of rejection, and allowed the pig kidney to continue functioning well for nearly 3 weeks until the study concluded. It was a clear demonstration that our existing antibody management tools can be effective against rejection in the xenograft setting.
That's incredibly promising. It shows the universality of these approaches. But you mentioned there was a slight theoretical concern, a caveat, about using IVG specifically in xenotransplantation.
Yes, it's a subtle but important point. Remember, IVIG is a pooled blood product derived from thousands of human donors. The theoretical concern was whether this pooled human IVIG might contain low levels of pre-existing anti-pig antibodies, non-gal antibodies, that are naturally present in some people in the general population.
So giving IVIG could potentially introduce new antibodies that might attack the big organ.
That was the theoretical worry. Could IVIG inadvertently worsen or accelerate rejection by providing a fresh supply of anti-pig antibodies? However, in that specific pig kidney case report we just discussed, the PEX-IVIG combination was clearly beneficial overall and didn't seem to cause any adverse sensitization.
So the benefit of managing the known rejection seemed to outweigh that theoretical risk.
It certainly appeared that way in that instance. But it highlights the complexity. It also strongly suggests that pre-transplant apheresis using PEX or perhaps immunoadsorption might become standard practice for almost all xenotransplant recipients in the future. Not just to remove potentially cross-reactive anti-HLA-SLA antibodies, but also to clear out any baseline levels of natural anti-pig antibodies before the organ even goes in. Apheresis looks set to be a cornerstone of clinical xenotransplantation.
Okay, let's try to bring all these threads together. We've seen this incredible evolution from basically just hoping for a match to actively intervening with desensitization, apheresis, managing recurrences, and now even pioneering xenotransplantation. Looking at the current landscape, what's the consensus among the major expert bodies like ASFOR or the European Transplant Societies regarding these intensive therapies? Are they fully accepted now?
The consensus is really quite solid and consistent across the key organizations. Therapies like PEX and immunoadsorption, when used as part of established desensitization protocols, typically PEXIA combined with IVIG and rituximab, are now considered accepted, evidence-based, and often necessary interventions.
For which situations specifically?
For managing ABO-incompatible transplantation, for desensitizing selected highly HLA-sensitized patients who can't find a match through KPE, for treating acute antibody-mediated rejection episodes, and, as we discussed, for managing recurrent FSGS. These are generally Category 1 or 2 indications in guidelines like ASIs, meaning they are standard or generally accepted practices.
And the overall message is?
The overarching directive that comes through is clear. Always prioritize finding a compatible match, ideally through KPE if possible. But critically, do not simply leave a highly sensitized patient languishing indefinitely on dialysis if a pathway involving desensitization with a living or even deceased donor might offer them a chance at a successful transplant and improved survival. The data supports intervention over inaction.
We've talked a lot about removing antibodies with apheresis and hitting the B cells that make them with rituximab. But what about tackling the real long-term culprits, the long-lived plasma cells, those antibody factories that can persist for years or decades and are often resistant to standard drugs?
That's exactly where much of the cutting-edge pharmacological research and clinical trials are focused right now. Plasma cells are notoriously difficult to eliminate because they don't divide rapidly, which is what many standard immunosuppressants target. So we need different strategies to deplete these established antibody factories.
And what kinds of drugs are showing promise there?
Two main classes are getting a lot of attention. First, proteasome inhibitors like bortezomib.
Bortezomib, isn't that used in treating multiple myeloma to plasma cell cancer?
Exactly. The same principle applies. Plasma cells are protein-producing machines churning out vast quantities of antibodies. This process generates a lot of internal stress and protein waste. They are highly dependent on the cell's garbage disposal system, the proteasome, to handle this load.
So bortezomib jams the garbage disposal.
It does. By inhibiting the proteasome, bortezomib causes toxic waste proteins to build up inside a plasma cell, overwhelming it and triggering apoptosis-programmed cell death. So it provides a way to directly kill off these long-lived plasma cells that might be resistant to other drugs. It's being used increasingly for difficult desensitization cases and treating refractory AMR.
Okay, proteasome inhibitors are one approach. What's the other?
The other major target is a protein called CD38, which is highly expressed on the surface of plasma cells. There's a monoclonal antibody called daratumumab that specifically targets CD38.
Also used in myeloma.
Daratumumab binds to CD38 on plasma cells and triggers their destruction through various immune mechanisms. So both bortezomib and daratumumab represent targeted strikes against the plasma cell itself, offering hope for more durable suppression of antibody production in really challenging cases.
And we shouldn't forget the complement inhibitors we mentioned earlier, like eculizumab. They still play a role.
Absolutely. Complement inhibitors remain a crucial part of the armamentarium, particularly for preventing or treating hyperacute or very early aggressive AMR. By blocking the complement cascade at a key point, like C5 for eculizumab, they act like an immediate fire break, preventing the downstream tissue destruction while other therapies work on the underlying antibody or cellular issues. They buy critical time.
All these different tools, apheresis types, rituximab, IVIG, bortezomib, daratumumab, complement inhibitors, it really points towards needing a more personalized approach, doesn't it? We can't just use a one-size-fits-all protocol for everyone.
That's exactly where the field is heading, towards precision immunomonitoring and personalized therapy. We've already mentioned using MFI levels to quantify antibody strength, but the next level is not just measuring the quantity of antibody, but assessing its quality or pathogenic potential.
How do you measure the quality of an antibody?
One key way is to see if the antibody can actually activate the complement system, which is the main mechanism causing tissue damage in AMR. There are assays available now, like the C1q binding assay.
C1q. That's the first step in the classical complement pathway, right?
It is. This assay checks if a patient's specific DSA can actually bind C1q after it binds to the donor HLA antigen. If it can bind C1q, it means that antibody is capable of initiating the destructive complement cascade. If it can't bind C1q, even if it's present at a high MFI level, it might be significantly less dangerous.
So two patients could have the same high MFI score for an antibody against the same donor HLA, but if one patient's antibody binds C1q and the other's doesn't,
they might warrant very different treatment approaches. The patient with the C1q binding DSA might need aggressive desensitization or closer monitoring, whereas the one whose DSA doesn't bind C1q might potentially proceed with transplant with less intensive intervention, or perhaps just heightened surveillance.
That makes so much sense. It's about tailoring the intensity of the therapy to the actual measured risk posed by that specific antibody in that specific patient.
Precisely. It helps avoid overtreating patients who might not need aggressive therapy, and thus sparing them the risks of infection and side effects, while ensuring that those with truly virulent complement-fixing antibodies receive the robust treatment they need. The future is definitely about using these sophisticated assays to create a personalized immunological fingerprint and guide therapy accordingly. #outro.
This deep dive, it really paints a picture of a medical field undergoing a stunning transformation. We've moved from a place where incompatibility was often an absolute barrier, forcing patients into years of dialysis or waiting, to an era where we can systematically tackle those immunological threats.
Yeah, whether the threat comes from HLA mismatches, ABO blood types, or potentially even xenoantigens in the future, we've developed this incredible arsenal of tools, desensitization protocols using apheresis, targeted drugs to neutralize or manage the danger.
And the evidence is just undeniable, isn't it? The data clearly shows that successfully transplanting patients, even across these significant immunological barriers using these techniques, leads to far better long-term survival compared to keeping them on chronic dialysis. That's the ultimate justification.
It really is. We've developed PECs as the broad clearing tool, more selective methods like DFPP and highly specific immunoadsorption, plus the drugs like rituximab, IVIG, bortezomib, daratumumab that target the antibody production machinery at different levels. Together, this toolkit has dramatically expanded the potential donor pool and offered real hope, life-saving options to patients who previously had very few, if any.
So let's think about the future then, for you listening, considering this field. For decades, transplant medicine has operated under the shadow of organ scarcity. That scarcity forced us to prioritize finding the perfect match, the immunologically simplest path.
But what happens if, or perhaps when, xenotransplantation fulfills its promise? If we reach a point where genetically engineered pig organs provide a potentially unlimited supply, the entire paradigm shifts.
How so? The scarcity problem disappears.
And if the organ itself is no longer the limiting factor, the focus shifts entirely. It moves away from the desperate search for the perfect match and squarely onto optimizing the immunological management for every single recipient.
So the challenge is no longer finding an organ, but making sure the recipient's body accepts the organ we can provide.
Exactly. In a future of unlimited organs, every patient needing a kidney could theoretically receive one. The central task of transplant centers would become deploying these sophisticated desensitization, apheresis, and monitoring techniques proactively, precisely, and universally to ensure graft acceptance and long-term survival for everyone, regardless of their initial sensitization level.
Which leads to a really provocative final thought. We're using genetic engineering to close the immunological gap between pigs and humans. We're using apheresis and desensitization to close the gap between incompatible humans. These tools seem to work across both scenarios.
So, if xenotransplantation provides the organs, and apheresis provides the means to manage rejection in almost any setting, could therapeutic apheresis evolve from a specialized treatment for high-risk cases into a routine, perhaps even prophylactic cornerstone therapy for all transplant recipients in that future? Will the blood cleaners become the most critical players in a world awash with available organs?
It suggests a future where the main bottleneck might not be biology or immunology anymore, but simply the infrastructure and expertise needed to apply these powerful antibody management strategies on a massive scale. A fascinating place to end our deep dive today.